Happy Thursday, friends. Welcome to another episode of VMR. Charmaine and Robbie edition today. We're so excited that you could join us. I look forward. I was just like telling Anne Marie, Curtin, and Rafa that I just love Thursday VMRs and something for me to always look forward to hang out with some of my favorite people. And so please join us. If you have a case to present, please volunteer in the chat. If you would like to discuss with RG and I, please volunteer too. In the meantime, the one and only Kartan has gracefully accepted to reflect on yesterday's case. I heard he presented an absolutely a great case, and I can't wait to learn from him. Unfortunately, I missed it. So, Kirtan, teach me, friend.
Yes, I don't know I can teach you, but I can surely reflect on it. Yes, so good morning, everyone. Yeah, yes, so good morning, everyone. Yesterday, we had amazing discussion by Stephanie, by Sevan, and by Colin and Ravi. And all of them discussed brilliantly. Even in the chat, Anne-Marie, Kushal, all of them had lots of pulse, and they actually got the diagnosis even before half the case was over. So it was a short and sweet case. And I just wanted to share that what I have learned from CPE solvers and the Rabi and Reza's discussion, that there are various biases that we have in approaching a disease. So if you look at yesterday's case, so we had a 19-year-old patient who presented with the fingertip pain and paresthesias. So of course, initially we thought about, could it be related to cryoglobulinemias? Could it be related to cold agglutinin disease? Because the patient had mycoplasma pneumonia infection, and following that, all these things happen. So it will make perfect sense, right? I mean, if someone develops cryoglobulinemia or cold agglutinin disease due to mycoplasma pneumonia, then it can explain everything. But furthermore, we have to take a step back and realize that what if this patient was indeed a female? And what if the patient never had pneumonia and presented with fingertip pain and paresthesias? Then you would think, well, this seems like a case of antiphospholipid antibody syndrome, because usually autoimmune diseases like APLA and SLE are more common in females, right? So if we take out that bias, that what if this patient is not male? What if this patient is female and presenting with fingertip pain and paresthesias? Then APLA would make perfect sense. So that was one of the biases. Then furthermore, in the laboratory data, we find out that the APTT was elevated. So it was around 110. And after performing the mixing studies, it never corrected. So first thought that we would have is that, okay, maybe the patient has some inhibitors to clotting factors, right? But then again, we have bias there, because we know that in clotting cascade, apart from the clotting factors, we have many other things. We have endothelium, we have fibrinogen, we have calcium, we have phospholipids, and all of those things won't be corrected by mixing studies. And that's why we have something known as DRVVT, that is the Russell Viper random test, to eradicate these biases that we have in order to diagnose APLA. So after the mixing study was done, and when we specifically added the phospholipid into the mix, then the APTT corrected. So, that was kind of final nail in the coffin, that you have to think about your biases, that what does APTT signifies in turn. So you have to think about calcium and everything else. And so it was a perfect case, and eventually anti-beta-2 glycoprotein and lupus anticoagulant was positive. And take-home message was that as usual, numerous infections can have post-infectious sequelae, and mycoplasma pneumonia is king of that. We know mycoplasma pneumonia can cause so many things: meningitis, arthritis, rash, you name it, it causes everything. And to cap up the list, we have this new association that it can cause antiphospholipid antibody syndrome. So it was a very nice and humbling case. I learned a lot from discussion. So thank you everyone for participating yesterday.
Kirtan, the entire time I'm like, wow, you are amazing, my friend. Like your understanding of like pathophase, your teaching skills, it's just so fantastic. I would love to borrow your brain at some point and just to see like what it feels like to have that much amazingly stored knowledge. Maybe one day we'll have the technology to do that. Thanks so much for reflecting. RG, how's that watermelon coming along?
There's not much left. That's so good. Some watermelon after a run, I highly recommend it. The only thing sweeter than watermelon is having a case presenter and 2 discussants already. Can you believe it? I don't have to guilt trip anybody.
I know. Although I love your guilt trips, it's kind of nice that you didn't have to do that today.
I know. You can only use them so much. Raphael is very kind and volunteered to present a case. Do you want to say hi?
Hi everyone, my name is Rafa. I'm from Brazil. I'm a 5th-year medical student, and today I have an interesting case. I hope you like.
Amazing. Wonderful. Welcome. How's your day going so far?
Well, I woke up, had breakfast,
Yeah.
and next week I'm starting my 2 last years of medical school. I don't know how you call it in USA. In Brazil, we call internship.
How are you feeling about it? Are you nervous, excited?
Yeah, I'm a little anxious, nervous.
Oh, that's very kind of you to join us despite that. We're going to miss you. I know you're probably going to spend less and less time here. So thank you for presenting a case today. Lion, hello.
Hello everyone. Hello, I'm the Lion and I'm speaking from New Delhi, India. Really, really excited to be here. And what can I say anymore?
You know, India is a land of many bright colors, and I can't help but notice the two people who are from India who have their videos on now are wearing bright red and bright green. Just making a comment on that, and how evocative of joy it is. Thank you for that deep smile and that deeper green shirt. Promise, hello.
Hi, Ravi. I volunteer because last time you said I will be discussing at some point. And this is my first time meeting Charmin. I think I'm relatively new to clinical problem solvers. I'm starting 2nd year in 2 weeks. I'm super nervous, but I'm also really excited to learn all the mechanism of disease and pharmacology and things that I am learning from solvers right now. And then I also feel a little pressure because I know Lilion's so good. Like I've heard his discussion last week in the non-English speaker VMR, and he was like on fire. So I have a little pressure.
Oh, no, not at all.
Promise, is such a pleasure meeting you. And can I just tell you, you're such a boss. I was nowhere near where you are when I was like a 2nd year medical student. And the fact that you're here, you're learning, it just shows you what an incredible growth mindset you have, that you just like want to keep learning and improving. And I promise you will have a lot of fun. And there is 0, 0, 0 pressure. Okay? You got it. This is such a power crew. RG, do you want to take the first aliquot, my friend?
Got it. You got it. Since Promise is such a Charmin fan, I'm gonna steal Nalayan again.
Sounds good. I get Promise.
Exactly.
I think in this case, it's a win-win situation for both of us.
All right, Rafa, take it away, my friend.
Okay, so it is a patient with 57-year-old male with chest pain.
This is a good place to stop, right, Rafa?
Yes.
Okay, all right, Nalayan, mesmerize us, please.
So I have been here before. For some reason, we have chest pain. So 2 chest pain and 2 rashes for me.
2 rashes,
All right.
yeah, exactly.
And as Kushal has mentioned, so we will first look for emergent causes. And let's see if I can remember them all. So we have 4 + 4 + 2 schema. And let's cover the 2. So for 2, we have esophageal rupture and esophageal impaction. For the 4 causes, we have 4 lung causes and 4 cardiac causes. So for 4 lung causes, we can have something like pulmonary embolism, pneumothorax, hemothorax, and maybe pneumonia. But pneumonia will present more as a pleuritic chest pain. So I will be very interested in knowing what type of chest pain this is. And for the 4 cardiac causes, I remember is that 2 A's and 2 T's. And aortic dissection, ACS, and cardiac tamponade. And let's see, I missed one more. Oh, Takotsubo cardiomyopathy. So 4 + 4 + 2 schema to check for all the emergent causes of chest pain. But then we have to move on because chest pain can have several different etiologies. I recently studied in surgery that we can also have cholecystitic chest pain. That is the colicky chest pain that usually presents that usually starts in abdomen can have a presentation in chest as bradycardia and chest pain. I think Kirtan presented a case in which we had a very atypical presentation of chest pain of MI, which didn't have chest pain. And MI in elderly can present as atypical, can have atypical presentations. Chest pain, sorry, I was digressing. It's important to know what the character of this chest pain is. If it's something like burning, so maybe a simple case of GERD. If it's a deep substernal pain, then I will think more in terms of MI and cardiac-related causes. If it's pleuritic chest pain, then maybe a pleuritis or pericarditis. And not to forget the rash, as in zoster rash, which can present as chest pain even ahead of rashes, or any rib-related causes such as osteomyelitis of the ribs or a fracture or Tate syndrome. That is, I'm not sure. I think costochondritis, idiopathic costochondritis, and that's all.
Absolutely brilliant. I love how you anchored us in the 4+2+2, and you nailed it, all 8 of them. But if you listen to the podcast, Reza will claim that there are 9, but in fact, 4+2+2 is 8, which I like to remind him all the time. I think not only did you teach us the importance of recognizing the sinister causes, but also reminded us of one very important thing. And that important thing is that we really tend, in our teaching and in conversations, make the case a lot that chest causes of disease can present as an upper abdominal pain, congestive hepatopathy, inferior myocardial infarction. And here you're teaching us the inverse is also true, that upper abdominal pain can present as chest pain. And I've had cases of pancreatitis present as chest pain. I've had cholecystitis. I've also had a gastric volvulus present as chest pain. So I really, really appreciate that point. And you've left me with very little to add, but actually I'll spend a minute reflecting on an area of increasing interest of mine, which is we really talk a lot about being parsimonious with our diagnostic testing. So we say, you know what, do you really need this test in this person? And I'm coming to believe that you also need to do that with the history too. Your time with the patient is not limitless. So while in medical school and in training, you have to learn all the questions you can ask. By the time you are officially done with your training, you should have a sense of what is helpful to ask in this patient and what is not. So maybe I can share what I find helpful. If I only have 4 or 5 questions in a patient with chest pain because the emergency room is full of people, what would I ask them? And the first question I would ask them is if the pain is ongoing right now. If the chest pain is ongoing, that changes things dramatically, because if it weren't ongoing, aortic dissection, pulmonary embolism, pericarditis, Takatsubos, esophageal rupture, esophageal spasm, all those things are virtually impossible. Having aortic dissection present a stuttering chest pain, highly unusual. Having a pulmonary embolism presenting a stuttering, coming and going chest pain, highly unusual. So if the chest pain comes and goes, the only real sinister cause left is acute coronary syndrome, which has that feature of perfusion ischemia. So my first question is, are you having chest pain right now? If the answer is no, the probability of aortic dissection, the probability of tamponade, Takotsubo, pneumothorax, pulmonary embolism, esophageal rupture impaction has plummeted just with one question. The next question I ask is if there's evidence of dyspnea. Because Nalayan, you said it earlier, like there are 4+2+2 is the sinister causes, and then there are the non-sinister causes. The presence of shortness of breath confirms the presence of a sinister cause. If you have chest pain and shortness of breath, you don't have costochondritis, you don't have zoster, you don't have a musculoskeletal cause. So the presence of shortness of breath makes a benign cause of chest pain very unlikely, very, very unlikely. So when you walk into a room and the patient has chest pain and you have 2 questions to ask, I would say the 2 most important are, is it ongoing right now? If it's not going on, it's probably the only sinister cause left is acute coronary syndrome. If there's chest pain is accompanied with shortness of breath, it's unlikely to be zoster or anything benign. So put that in your back pocket, and we'll see what Rafa tells us about this patient.
Okay. The patient reports chest pain, dyspnea, and palpitations with a duration of 2 weeks. Intermittent symptoms worse on exertion, improved with rest. Associated symptoms, weakness and fatigue, then eyes, fever, chills, leg swelling, orthopnea, nocturnal dyspnea, or recent weight loss.
All right. Rafa, is this a good place to stop?
Yes.
Okay.
Then I start with the past medical history.
Sounds great. Robbie and Nilian, I'm such a big fan of you both. That was such a fantastic discussion. Promise, friend, how's it going?
I feel like this, like I can't really narrow down to anything. I feel like I'm still on like the broad range. I thought the weight loss was really interesting because I feel like usually chest pain doesn't, especially like if it comes from the lungs or the heart itself, it doesn't come with weight loss. So that makes me curious to look more into the history and think about like would there may be some abdominal issues, or something that leads to the weight loss, and then, or actually it denies it. Okay, never mind. Thank you, Rafael. So then I think like the worsens on exertion, like their shortness of breath, that's definitely something to clue in. I don't really have a schema for that, but I think that makes me think more less of like infection, but more towards, actually I'm not sure, maybe there could be infections with that too, but I'm thinking more towards like the lungs and the heart problem. And then something I thought about, since I don't know too much about the diagnosis schemas yet, I feel that when I heard chest pain, I was thinking like either, like there could be different causes of it. Like it could be um, systemic, like something else that leads to a chest pain, or it could be coming like straight from the organ itself. So that's kind of what's in my mind right now. Yeah.
That's fantastic, friend. I wish I was half as good as you when I was in your stage, friend. That you're absolutely right to say that, like, hey, you know, this chest pain is coming with the shortness of breath. You're worried about the cardiopulmonary system, and you know, they're neighbors of each other. So a lot of the disease processes. When it affects the heart, it can affect the lung. Sometimes when things are going with the lung, it can affect the heart. So they're neighbors. So one of my favorite analogy to use is like, hey, if your house is on fire, your neighbor's house is getting pretty hot. So, and when we think about like chest pain in general, like your cardiopulmonary etiologies are the most likely. They're like kind of like, if you think about base rate of disease, they are a majority of causes you want to think about the cardiopulmonary system. So you're really right on track to just hone on to those things. And the fact, as like Robbie mentioned, like now we know like this chest pain, we need to worry about it and work it up because it's accompanied by dyspnea and dyspnea on exertion. Whenever I hear like dyspnea with exertion, I think the thing that we have to kind of like entertain is, hey, if this is a patient, I think experiencing like an anginal equivalent, so a chest pain that is manifestation of a coronary artery disease in someone who's 57 years old, something to definitely consider. Again, thinking like common things being common, we don't want to miss someone who has worsening coronary artery disease. So that's something to definitely, in all comers, we should all like think about. And the fact that it's like been going on for 2 weeks is also informative. If somebody's coming in with like acute chest pain, if you're thinking about a STEMI, a perforation, any of those things, we think about like acute pathology. So, although, gotta be honest with you, like not that many patients read the textbook. So, especially the patient population that I have the privilege of taking care of, they are they are strong, resilient people, and sometimes show up 2 weeks after they had a STEMI because, you know, why not? So again, you want to always like put the complaints that you hear in the context of this patient. So getting some background information, as you mentioned, about like, hey, who is this patient? Is this patient who has multiple comorbidities that would help us clue in what's the etiology of the chest pain, while always like making sure we're not dealing with any of the emergent causes of chest pain. And I actually really, really loved in the beginning when you thought patient had weight loss that you clued in, because it felt like it doesn't go with the rest of it. I thought that was really, really, really great reasoning. Promise. Awesome job, friend. I can't wait to hear more.
So jumping to past medical history, he has no history of lung or heart disease, and he's not on any meds. He's a 40 pack year smoker, quit a few years ago, and transitioned to e-cigarette. He stopped using when his symptoms started. I think that's good for now.
What are you thinking, my friend Alain?
Sure. So I think we discussed about chest pain having dyspnea, and then we got dyspnea. But then, as Charmin mentioned, 2 weeks is a little too long to be thinking of emergent causes. But then some patients are fighters, and we can have STEMI 2 weeks after having acute attack. And I think the more information the new information we have right now is a 40-pack history and on e-cigarettes. So we have had a case of e-cigarette induced lung damage. So maybe that is on differential. And 40-pack history translates to two broad differentials in my mind. Number one would be a lung carcinoma, and number two would be any form of COPD or even a restrictive lung disease. So, but for a COPD or a restrictive lung disease to present as a chest pain would be slightly unusual in the presence of palpitations, because I localize palpitations to heart. However, that is not specific because I think something like more than 50% of palpitations are just secondary to anxiety. And 57-year-old male having anxiety plus another issue that may or may not localize to lung is a bit odd. So maybe in this case, we can localize palpitations to a heart and say that maybe the left atrium is getting dilated. My initial thought was dyspnea plus palpitations equal MS. In context with so much rheumatic heart disease, dyspnea and palpitations in a 57-year-old equals a rheumatic heart disease with MS. So my first thought was naturally that, but with the 40-pack history, I think it has translated more in terms of primary lung pathology. But smoking can affect heart. I'm not sure if there's any specific disorder, maybe a vasculitis that has kicked on, maybe SLE. 57-year-old male having SLE would be unusual. But primary lung condition having palpitations, I'm not sure how to relate these two. Maybe primary arterial hypertension, but then that would dilate the RV, and then that would dilate RA, and maybe that way we can have palpitations. Or maybe smoking is kicking some other condition. Maybe the patient was subclinically hyperthyroid, and smoking just made it worse, and then the patient is now clinically hyperthyroid, and that's how he has palpitations and dyspnea, because we know thyroid can do that, and smoking just unveiled it. So yeah, that's what I'm thinking.
So many inferences from such little data. I love it. I think you're right to say that palpitations means that the heart is beating probably too fast, right? When I think that when patients report palpitations, I'll tell you that there are numerous studies to suggest that when they have prolonged monitors, there's actually not much incidence of even tachyarrhythmias. And most people with palpitations actually have a normal heart. And so palpitations is really a neurological phenomenon of a perception of abnormal cardiac activity, but most people actually have normal cardiac activity. But if you do believe that the heart rate is abnormal, it's hard without further history to determine if it's sinus tachycardia or an arrhythmia. And so you can think of many lung diseases that cause palpitations via sinus tachycardia. And only when you prove that the palpitations are non-sinus do you start to venture about the heart being the problem. But even when you find a non-sinus rhythm like atrial fibrillation or multifocal atrial tachycardia, sometimes the problem is actually in the lungs itself. So pulmonary causes of palpitations are many. And for reasons that Charmaine alluded to, you know, the lungs are the heart's neighbor, and they can induce a sinus tachycardia through advanced pulmonary disease, or cause adjacent cardiac anatomic issues that predispose to arrhythmias, not just sinus. And I love that you explored the connection between smoking and cardiopulmonary complaints. And you know, there are three big categories of smoking-related diseases. And the three big categories are smoking-induced lung damage in the form of COPD most commonly, but also some interstitial lung diseases attributable to smoking. Smoking also damages blood vessels anywhere, coronary artery disease, cerebrovascular disease, and does some fancy things to blood vessels. And only because Kirtan is here and we haven't mentioned vasculitis yet, we have to at least mull the possibility of Buerger's disease or thromboangiitis obliterans, but then take that and put it in the trash because it's probably not happening in a patient without any extremity complaints. And the final complication of smoking, in addition to lung disease and vascular disease, is high risk of cancer. Cancer of the lungs, cancer of the bladder, cancer of really almost everywhere. But we know this patient isn't just smoking. I think you alluded to the possibility of EVALI, which is e-cigarette and vaping associated acute lung injury, which is a phenomenon that we're only really learning about. And I'm curious to see if that's a possibility. It mostly is centered on the lungs with some maybe pleuritic component causing the shortness of breath. So I think we're right there. We're still centered on the heart and the lungs. And this new data, the smoking history is compatible with both lung disease and cardiac disease. The e-cigarette history is much more compatible with lung disease. Either way, we're very worried about this patient because of chest pain, dyspnea, palpitations, and an exam and diagnostic data will help us make a lot of progress, I'm sure. All right, Rafa, back to you.
Thanks, Rabbi. So in the vitals, blood pressure is 131 to 71, heart rate 74, RR 18, O2 saturation is 99 on room air, temperature 36.4 Celsius, and BMI 23.7. He has no acute distress, pale conjunctiva, heart regular rate and rhythm, lungs clear to auscultation, no peripheral edema, and that's it.
All right. I love a normal exam promise. So let's dig into this we can tag team this. All right. First of all, any questions so far, friend?
No, but I thought like the vitals are all really normal except blood pressure slightly higher, and that's like heart rate is also normal. So that was a little unexpected because I was thinking something more interesting. Yeah, and then general exam, there's nothing that stands out. Definitely want to hear more about the chest and pulmonary exams and see what that is like. And also maybe because someone mentioned that thyroid could be a thing, so maybe looking at the thyroid gland exam, like seeing that.
Yeah. No,
Yeah.
absolutely, friend. Yeah. And you're absolutely right. In this like snapshot in time, the vitals are completely normal. I would say people, we're dynamic creatures and our vitals are dynamic too. So this is someone that we're going to closely monitor, and especially when it comes to heart rate, right? Our heart rate rarely just stays in the 70s, right? So especially as Nilian and Robbie talked about, like this patient experiencing palpitation that we think it might be related to his heart, then this is someone that like we want to put on telemetry to just keep monitoring those heart rate. And as soon as like that heart rate, you see some variability, getting an ECG. I still think ECG is the first thing we're going to get in someone with chest pain, just to make sure, A, we don't have any ischemic changes, and B, is there anything other pathological thing going on, like, you know, AFib with RVR or AFib that can turn into AFib with RVR. So at this time, yes, the vitals are assuring. However, again, the complaint of chest pain is the one that even a normal vital sign doesn't reassure us too much because we still need to work it up. And In terms of like a cardiac exam and lungs that are normal, a few things come to mind, right? Getting a really, really good exam, for example, in a busy setting, it's hard to do. How many times do I really, really can hear a heart sound like or murmurs in a busy emergency rooms? That is my limitation, right? So always like having a grain of salt is like, hey, there might be a pathology that we're just not catching. Another thing a normal exam usually makes me think of issues that are episodic, right? Like if you're having spasms, like coronary artery spasms, and if the patient is not having spasm at a time, you might get a completely normal exam. You're not gonna, if patient is not pain, their blood pressure might not be elevated. And with lung in general, clear lungs, a lot of the time we makes us think of the vasculature of the lung, because like that doesn't make any sense. Those Akira has this amazing hypoxemia thought train that I love, and part of that thought train promise is about like what makes sounds, right? So it's like your alveoli, your bronchial tree, those are the component that allows us to hear the sounds of like crackles, rails, like wheezing. It comes from the airway. So the vessels are sitting there if a patient has a PE or a patient has pulmonary hypertension, and the lungs are beautifully, beautifully clear. So that might be a reason for the clear lungs. The other thing to also think about in people who, for example, sometimes come in with like asthma exacerbations, you might not hear much wheezing, and we really worry about those patients because it might just be a function of like them not taking deep breaths. So in order to like hear really good breath sounds, you want to make sure those breaths are deep so you can actually pick up sounds. So again, like exam is quote unquote normal. It doesn't mean there's not a pathology hitting there. So that's when we rely more on our ECGs, labs, and imaging to see if we can pick up something. But a 57-year-old chest pain, dyspnea, normal exam, gotta dig deeper. So Rafa, promise, any other thoughts before we turn it to Rafa? Awesome, friend. Rafa, can't wait to hear more.
Okay, so on the labs, we have a white blood count of 74,000. Do you want me to say the percentage of? I think I'm gonna skip this part. But the hemoglobin is 5. The hematocrit is 16%. MCV 109. MCH 35. Platelets 14,000. I think for now, that's all I can give you.
Oy, what a twist. Rafa, can I ask one question?
Yes.
Is white blood cell count normal or high?
High. It's 74,000.
Oh, 74,000. That's high, I think. Wow. Okay. My friend, Lion, where are you at?
Oh my God. With anemia in a 57-year-old man, I was thinking in terms of colon carcinoma, but this has turned my differential upside down. So WBC of 74,000 I can interpret it in two ways. Either the patient has leukemia or the patient has leukemoid reaction. So leukemoid reaction is WBC that high, but secondary to an infectious cause. And the patient didn't have a fever. And even if I were to think of infections, I would have thought of maybe the patient had minor illness and then patient developed myocarditis, and that explains the symptoms as well. But having a WBC that high with a current complaint of dyspnea and palpitations puts infection lower down. So WBC that high, I am thinking in terms of cancer right now. Hemoglobin of 5 with MCV of 109. So MCV of 109 can be taken two ways. A, the patient has megaloblastic anemia, megalocytic anemia, or macrocytic anemia, let's put it that way, macrocytic anemia, or it could also be secondary to radiculocytosis. As we know, when the hemoglobin goes low, there is a reticulocyte production, and reticulocytes are huge as compared to normal RBC. So they drive MCV to a high levels. So MCV of 109 can be a reticulocytosis. So I would ideally like to have a retic index here. However, 109 is too high a figure to me for me to think of a reticulocytosis here. So maybe we have macrocytic anemia secondary to other causes. In the face of having pancytopenia, okay, we don't have a pancytopenia here, WBC is that high, but I was thinking in terms of maybe overlapping B12 deficiency as well. But we have nothing to suggest of that. So yeah, of course, it can be secondary to marrow infiltration as well. If it's leukemia, then bone marrow can be involved, and then something like myeloabscessic anemia. If it's really a leukemoid reaction, then maybe an autoimmune infection, an autoimmune process causing WBC to be that high. Something like sarcoidosis. I'm not sure if sarcoidosis can present that way, but if Ketan is to be believed, it can present anyway. So maybe sarcoidosis, but with granulomas in bone marrow, which is just driving out all the precursors to make RBC and platelets. So maybe that's also a possibility. MCH of 35, all right. Hematocrit of 16, too low. Platelets of 14,000, too low. Yeah, so that's what I think. Peripheral destruction doesn't seem very likely here. And okay, low platelets with anemia can also be interpreted as MAHA, but I don't think that's the case here. Nothing suggestive of that. So like DIC, TTP, HUS, scleroderma, HELP, like I don't think so. We have that on our hands here. So yeah, that's what I'm thinking.
Absolutely brilliant, my friend. I love your initial breakdown. You're like, the cells are really, really high. Is this a reactive process like a leukemoid reaction, or is this a primary clonal process? And the clonality could be many things. The clonality could be blasts. The clonality could be differentiated cells like myeloproliferative neoplasms, or the clonality could be lymphocytes. For example, you might have CLL, you might have CML, or you might have AML all present with a white count this high. In terms of trying to distinguish between a leukemoid reaction where their body is reacting to something else, the key question often is, how shocked are you by the white count? In patients with severe systemic syndromes like a horrible infection or a horrible drug reaction or an aggressive autoimmune disease, often you're expecting some degree of white count. And here we were looking for the EKG, instead we got a white count of 74,000. And if that's the case, it's probably much more likely not to be reacting to anything but to be clonal. And the question is the clonality lymphocytes? Is the clonality differentiated cells like would be in CML, where everything is elevated, including basophils, eosinophils, neutrophils, or is it blasts? And that's where you will know for sure. And this is how you know that Rafa is an expert presenter, because he's enriching this discussion by not telling us what the differentiation is so we can try to predict it. And I don't know, I think all of them are at play. How can CLL do this? CLL can do this through autoimmune hemolytic anemia and thrombocytopenia, which would be supported by the fact that the MCV is high, assuming the MCV is from reticulocytes. However, CLL is an age-related disease, usually affecting people over the age of 60. So he's a little bit young for CLL, though it's certainly very possible. CLL also rises to the surface in the form of diffuse lymphadenopathy usually, which is also absent here. Could this be AML? Of course, but then what's the deal with the MCV? It could be that he has myelodysplasia causing macrocytosis that has then progressed to AML. But again, he's very young for MDS, again, an age-related disease, unless he has a genetic predisposition to myelodysplasia, which is not uncommon in the world of MDS. And then finally, could he have CML, P. vera, things of that nature? Absolutely. It doesn't explain the macrocytosis as far as I know, but I'm really curious to see what the differential is, and that will shed a lot of light on what's going on in this case. All right, Rafa, back to you.
I forgot to say that the EKG was normal. And the white blood count differential, we have 40% blasts, 21% segmented neutrophils, 11% lymphocytes, 2% monocytes, 2% eosinophils, 6 metamyelocytes, 8% myelocytes, 4% promyelocytes. And I have 2 more tests that I can say later.
Woof, the twists and the turns, promise. What are your thoughts or questions or anything that you want to share with us?
Honestly, Charmin, I think you will have to help me out here because I don't know what these means. But I definitely echo with how the lion was feeling. Like this is like upside down because I was totally thinking more of like the cigarettes and pulmonary and chest problem, and then now it looks like it's definitely something with the blood and like everyone said, I don't think this is an infection. I feel like I'm just amazed at this point. So help me out.
Friend, you are exactly where we're supposed to be. And yeah, that was shocking to us too. And I think it's definitely a brilliance of Rafa presentation is that we started off talking about like things that are really common, chest pain, shortness of breath, cigarettes. And now we get a turn and we have to like think about the rare causes of like chest pain and shortness of breath. And with this elevated white count, the question for me in someone who's coming in with shortness of breath, to be honest, I also sometimes struggle remembering all of like AML, CLL, ALL. So that's something that I constantly having to review too. So do not worry if like these names are still like a little foreign. With that elevated white blood cell, the question becomes like, again, what is, as Robbie and Millian were saying, like what makes those big cells? Because you imagine like your vessels are tiny. And then you have these cells that are making up so much of your blood. The bigger they are, the more likely that they cause issues, right? Because they can get stuck in like in your organs that have really high vasculature. Like they can get stuck in your lungs, causing shortness of breath, causing issues. They can damage your kidneys by like getting stuck in the vasculature in the kidneys. They can cause altered mental status, which thankfully this patient doesn't have. So the bigger the cells are, the more I'm sweating. So when I see 40% blast, I'm like, my only question is like, where is the hemonc fellow and how can I get a hold of them right now? It's because these blast cells can cause a lot of issues. And with, I believe there were some myeloid, so sorry, I missed that part of the presentation, but like thinking about like AML, there's like it's a great thought. So with that blast, you want to jump, you want to get the hematology oncology fellow ready. Is that this patient you're quite worried about, given that there are like blasts on the smear. So my first call would be like, hey, stabilize this patient, hydrate them, and hopefully give them some, and then get the hemonc fellow, because this is someone that you want to think about like a treatment and further workup to imagine to see like what exact like hematology blood cancer you're dealing with, basically. So thinking about like, your leukemia, especially in an absence of big lymphadenopathies, is it's where I am at. So the other things to kind of think about when you see like blasts, because there are like, I think about them like pretty active cells, is that are we also thinking about do we need to worry about complications of malignancy? So we already like talk about like leukostasis, right? Like these cells getting stuck. They can cause hyperviscosity, which we don't see here. Usually that presents with altered mental status. The other thing you need to think about is like the cells that are fragile can burst. So thinking about like your tumor-lysis syndromes and all of those. It's also another thing to keep an eye on. So this is someone that you want to repeat labs very frequently. Just to be respectful of the time, I'm just going to stop there and to ask Rafa to give us some more information.
Thanks. Okay. So in the peripheral smear, we have many blasts with occasional arrow rods noted. The special tests, such as bone marrow aspiration, we have hypercellular marrow with diffuse involvement by acute myeloid leukemia, 75% blasts. I have one more test before the final diagnosis, but I don't know if I say it now.
Milan, what do you think?
75% of bone marrow has been infiltrated. Oh my God. Okay, so I had this theory of myelocytic anemia, and I think I will stick to it because, okay, seeing the number of blasts we have, 40% of the peripheral blood smear, and the slight left shift with 6% metamyelocytes and 8% myelocytes, I was already thinking in terms of AML, and then we have ORODs. So this is, I think, APML, acute promyelocytic anemia, leukemia, and APML actually has one of the better prognosis in the entire AML family. So the patient should do fine in the future. However, the blasts are too many. So maybe we have to, in future, we have to think in terms of tumor lysis syndrome. So maybe prophylactic hyperuricemia just to decrease the counts so that the patient does not have any symptoms of, let's say, leukostasis. I think someone mentioned in the chat that dyspnea can be secondary to leukostasis in the pulmonary artery. I think it was Ketan, as usual. So yeah, leukostasis can explain our symptoms, and given the high number of WBCs and the number of blasts, I think that would be at the top of my differential. However, to explain anemia and thrombocytopenia, MAHA is a very viable diagnosis here because APML is known to cause DIC, but the patient's vitals are so stable. I don't know if we can have that stable vitals with DIC. However, we don't have APTT or clotting time or bleeding time or PT or INR. So maybe running those studies will help us know what the cause of anemia and thrombocytopenia is. As such, bone marrow didn't reveal any evidence of myelocytic anemia. So maybe time to put it at the back of differential list. Those are my thoughts.
Absolutely brilliant. I'm right there with you. I think the hour rods are not specific towards APML. A small amount of hour rods are actually found in a variety of leukemias. And so while we learn for our learning that hour rods equals APML, it actually is more subtle. Many hour rods are specific for APML, and many is a subjective determination by the hemonc physician. I think just to share a little bit about APML, this is an unusual presentation because most patients actually present with leukopenia, not leukocytosis. So pancytopenia is the most common presentation. But there are a couple of clues here that this might have been APML. APML tends to present in younger patients. Most patients with leukemia are over the age of 60 or 70, although you will see patients who are in their 20s, 30s, 40s. And the clue is in the MCV. So the MCV, if suggestive of reticulocytosis, might have clued us into the possibility of peripheral destruction, again, in line with a DIC picture. So here the MCV really stands out. APML, as you said, is either great in terms of getting a cancer or horrible. Patients have a high chance of cure if they are well enough to reach the hospital and get treatment. A large fraction of patients present with devastating neurosurgical bleeding and devastating bleeding elsewhere. And as a result, actually, by your prognosis is determined by your stability on presentation. And if you are stable on presentation, you're likely to be cured. But if you come in very sick, your chances of death are very, very high. I'll say one more thing, which is that I forget what I was going to say, actually. What was I going to say? I lost my train of thought, which means I should probably stop talking and pass the mic to Rafa. Oh, Lion, were you going to say?
I just have a point, if it's okay.
Please, always.
I had this thought that with so much proliferation, could it be induced B12 deficiency, which would explain this macrocytosis?
I can see how you think that. I don't know the answer to that. I really don't, but I think it's something, because, you can overconsume anything. We talk about folate consumption in this context, and I don't know the answer to that. I think it's a great thought. All right, Rafa, take us home, please. What was the diagnosis and what did you do?
Okay, so they did a FISH that came out negative for 15-17 translocation and flow cytometry with increased CD34 positive myeloblasts, which expressed HLD, DR, CD 13, CD 33, and CD 11.7 with a diagnosis of acute myeloid leukemia.
Wow, humbling. Thank you so much. How did you, I'm just curious, how did you explain the hour rods and teach us more about what you learned in this case?
This is a case from human XD, DX. And they say there that with the hour rods, we have two possible diagnoses, most probable. We have acute myeloid leukemia and AMP, how do you say? AMPML. But the fish was negative. And PML usually gets positive fish for 15-17 translocation.
A humbling reminder that there's many things to learn in this case, but a small point that hour rods does not always equal APML. And here's a great example of that. I'll pass the mic to Charmaine and promise to reflect and share any thoughts, and then to Rafa, to our other friend Rafa, to do the teaching points.
This is such a fantastic case, Rafa. Thank you for presenting. It's kind of like my favorite diagnostic reasoning cases that allows us to reflect on like common stuff, and then takes a turn, and then we have to like go deep into hematological malignancies. Nilian, brilliant. Robbie, always a pleasure. And Promise, you're such a rock star. How did that feel?
Thank you. I feel like I'm learning so much because we took like physiology, so like I feel like I was just thinking a lot about the organ system problems, and then here it just took a huge turn. I think, like everyone said, it's very humbling, but also learning a lot. And then I just feel like recently in the VMRs, I've been seeing a lot of blood problems, like a lot of HUS and MAHA discussions. I'm definitely learning a lot. And thank you so much for all the teaching points and all your patience.
Oh my gosh, Promise. I love discussing with you. Can we do this again soon? I hope so.
Sure.
Yay! There we go. I'm just going to pass on the mic to Rafa for bringing us home.
So first, thank everyone who was involved today, and especially Rafa for presenting the case. It was such a difficult VMR for me because everybody was saying half, and I was like, oh my God, this is not me. I was having like some kind of problem trying to deal with all of that, but I think I did okay. So thank everyone who discussed today, and Charmaine and Ravi for facilitating. So we had a chest pain in a patient with 5-7-year-old, and we thought about first ruling out emergencies, and then there's mnemonic that we always have to remember in the setting of emergency, the 4+2+2, being esophageal rupture and esophageal impaction, ACIS, taxotubal, aortic dissection, tamponade, PE, pneumothorax. It's always very important to characterize the chest pain that the patient is having. For example, we could see if the pain is radiating, if it's new, or if it does get worse with movement, or if it's constant or comes and goes. If comes and goes, we have to think about ACS and ischemic process going on. And we also have to see if there's any dyspnea associated, because it could lead to, lead to etiology causes, sinister causes, sorry. And then we have to also think about abdominal etiologies leading to chest pain. And Rabi taught us about, for example, pancreatitis, gastric volvulus, and cholecystitis. And then we saw that this patient had a smoking history in the background, and we had to think about primary lung pathology as a consequence of the smoking history. And we thought about COPD, ILD, neoplasia, and pulmonary arterial hypertension. And then we discussed about tachycardia, which could be sinus or non-sinus tachycardia, the ECG will be your friend. And then we thought about pulmonary causes leading to tachycardia. For example, advanced pulmonary disease, but it could also predispose to arrhythmia, certain etiologies. And then we saw that this patient had a super elevated white blood count, and we had to try to differentiate a leukemotic reaction from a leukemia. And then your friends here will be the peripheral blood, because with leukemotic reaction, we have cells that are usually more mature than myelocytes, and also the LLP activity, because it's high in leukemotic reaction, below, for example, in CML. And also the basophilia, because basophilia is uncommon, but we have to think about myeloproliferative disorders when we see that on the blood smear, and we have to think about things like polycythemia vera, myelofibrosis, and also CML, classic CML. And then we saw that this patient had our rods, which are crystal aggregates of MPO, and there it's a danger to the patient because our rods can stimulate the coagulation cascade leading to GIC, and it's classically associated with APML. So thank you, everyone. I hope everyone enjoyed this case, and I hope to see everyone tomorrow.
Thanks, amazing Rafa. ×2. Promise, Robbie, a pleasure. Thank you for joining us. Can't wait until next week and tomorrow's VMR, RLR. Woohoo! Bye.